Good afternoon, everyone. Over the next 30 minutes, I will be talking about the late loss of the allograft. These are my disclosure, no disclosure. So let's first talk about the definition of late loss of the allograft. In transplant world, loss of the allograft 1 year after transplant is called a late loss. And it's important to point out that historically, this was not easy to achieve a 1 year mark post-transplant. And when you look at the data from the 1960s, it shows that only 40% of recipients will survive 1 year with a functional, the allograft will survive a 1 year mark. And there is 80% of allograft loss after 1 year. But over the past 40 years, with progress on a better understanding of the biomedical and mechanistic and therapeutical approach, we are seeing a longer life expectancy of the graft. And for sure, this will exceed the 1 year. And we can talk about two categories for allograft survival. One where there is a loss of the allograft and the patient is still surviving, what is called death-censored survival. And this is important because it gives us a better idea on the lifespan of the kidney itself, independently of how the patient is doing. And the other one is allograft function while the patient will expire or die. The overall survival, obviously, is when both graft failure and death with functional allograft are taken into consideration. Most allograft fails late, and the data now available shows that overall at 1 year, more than 95% of all allograft survival will survive, but after 10 years, there will be a continuous decline on allograft survival every year, with only 50% of the deceased donor will be reaching the survival rate, whereas 70% of living donor graft will survive. And the question is that often patients will ask you how long my kidney will last. And the answer we can provide based on the most recent studies, where the median survival of a deceased donor graft is 12 or 13 years, and around 19 to 20 years for a living kidney donor. So there are multiple reasons for which the allograft will fail. And you can see on this busy slide that could be either defined as pre-transplant or pre-operating, peri-operating, and post-operating reasons. And it can also be divided into immunological versus non-immunological causes. So this is what I was talking about. Pre-transplant allograft causes can be related to the donor, can be related to the recipient, whereas peri-transplant can go from something related to the HLA matching, the ischemia time, surgical complication, whereas the post-transplant cause for allograft failure can be divided into both non-immunological and immunological causes. So to talk a bit about the pre-transplant causes, I would like to start with a quick question about the KDPI, which is a numerical measure that combines 10 donor factors, including clinical parameters and demographics, summarizing into a single number the quality of a deceased donor kidney relative to other recovered kidneys. And I would like to ask you which one you think is not a variable for KDPI: age, race, creatinine, HCV status, or history of smoking. And the answer is history of smoking. And this is not part of the KDPI. And this is kind of surprising, but when the KDPI index was introduced in 2014, smoking was considered as a parameter but didn't reach the statistical significance. However, with the new data, it may be part of this calculator. I would like to start talking now about one of the most important causes of post-transplant allograft failure. And when we talk about late allograft failure, we cannot skip talking about allograft rejection. And the Banff classification has indeed transformed our understanding of the pathomechanism of allograft loss and how we approach also the definition and the treatment. The BAMF working group is a group that gathers every 2 years and work on defining and categorizing the different mechanisms of allograft injuries over time, with the intention to kind of unify histological changes seen mainly on the light microscopy. At the beginning, the late allograft injury was defined under a big box that we used to call allograft nephropathy, but that was not specific, including patterns of changes to the glomerular basement membrane, some changing to the arteries and the arteriole, interstitial fibrosis, atherosclerosis, and tubular atrophy. However, this did not and was not useful to guide on how we can treat patients based on these chronic changes and prolong their allograft survival. So my next question is, what do you think is the leading histopathological finding on a for-cause biopsy performed after 1 year of transplantation? Is it calcineurin inhibitor toxicity, BK virus nephropathy, antibody-mediated rejection, recurrence of the original disease, or T-cell mediated rejection? And the answer is the antibody-mediated rejection. So this is a Canadian paper that was published in AGT in 2012. It's one of the most quoted paper in kidney transplantation. And the authors actually performed a for-cause biopsy in 315 transplant recipient patients. They looked at the different histopathological findings up to 5 years post-transplant. And as you can see, if you wipe out all the first 5 years of transplant, you will see, like, past this time, there's a significant uptake of the antibody-mediated rejection. About half of the biopsies will show a pattern of antibody-mediated rejection in patients. So how can we define and what are the criteria for antibody-mediated rejection? And this is an important board question. So the diagnosis refer to 3 items: histological evidence of antibody-mediated rejection, either active or chronicity, evidence of presence of antibody interacting with the donor endothelium, and the serological evidence of donor-specific antibodies, or what we call DSA. So here are the main histological changes that define the antibody-mediated rejection. So pathological finding will show first glomerulitis, which is assessed and scored by a number of the mononuclear cells that will infiltrate the glomerulus. The second is the presence of peritubular capillaritis, which is also defined by the peritubular capillaries that are infiltrated by inflammatory cells. And here you can see severe cases when the score of the glomerulitis and the peritubular capillaritis is above 1 or equal to 1, we have the histological diagnosis criteria for antibody-mediated rejection. The second criteria is the evidence of presence of antibody interaction, represented by the linear positivity of C4d deposition along the endothelium and also along the pericapillar tubulitis. And this picture shows you a pretty strong staining for C4d. Whereas the third criteria is the presence of serological evidence of donor-specific antibodies. This is the result of anti-HLA antibodies screened in a patient after 1 year, where initially there was no anti-HLA antibodies detected, and then screen a few months later showed the presence of specific donor-specific antibodies, as you can see here in this box. There is also a possibility to screen for non-HLA antibodies that we can talk about later on. And these non-HLA antibodies include anti-ABO, MICA, or what stands for major histocompatibility complex chain-related molecule 1, and also angiotensin II receptor type 1 antibodies. So the 3 criteria will make the definition and the diagnosis of antibody-mediated rejection. But AMR remains a heterogeneous spectrum, as the Banff group can define the criteria based on higher resolution. So a patient can meet the three criteria, and if you are in the presence of histologic presence of the glomerulitis and the peritubular capillaritis, and the presence of a positive C4d and detected DSA, then you have the diagnosis of acute AMR. Where there can be cases where you will not fulfill all the criteria, and you will see either a low or absence of serum DSA, and also a negative or very focal and mild C4D positivity on the biopsy. And then this can fall under a different definition and can call for different treatment. And it's funny that the Banff group acknowledge themselves as a changing and progressing group. They acknowledge themselves that the work is still in progress and continuously in progress in working on this criteria of definition of the AMR rejection. And because without understanding the pathophysiology, we can probably not understand what is going on at the pathology level and come up with useful treatment. And here we can see some variation of the definition of antibody-mediated rejection and microvascular inflammation, as can be reported by the different Banff 2019 and 2022 criteria, where when we have presence of the three criteria, you will be under the definition of AMR, while if you are missing the C4D and the DSA, there will be not called AMR per Banff 2019, but there will still be described and reported as macrovascular inflammation by the Banff 2022. And let's briefly talk about the mechanism of C4 deposition. That is like an important criteria as well, where with the antibody will react with the endothelial cells and will start the complement cascade activation through the classical complement cascade, which leaves the C4D behind. And this is what we will be seeing on the pathology and on the immunofluorescence. But the final product would be making the membrane attack complex that will create a hole in the endothelial cells and will cause the injury. And again, because there is more recognized form of C4D negative AMR, and more studies are alluding that this could be related to the NK cell toxicity, since it has been shown that natural killers can also cause an attack of the cells, especially when cells, because of specific abnormal condition like viral infection, for example, can lose their MHC class 1 identity, which remove the inhibitory signals that mainly was here to prevent NK cells from attacking the cells. So we can see a clear antibody-mediated rejection without detected DSA and without presence of the three criteria. And both C4D and DSA are strong prognostic variable as well. And this figure shows in the dotted line at the bottom that patient with double positivity for C4D and DSA, but with only one of the criteria for the antibody-mediated rejection, meaning either glomerulitis or peritubular capillaritis, will still show very poor outcome when compared to patients who are double negative, as you see here in the solid line for C4D and DSA. So treatment for AMR is still not standardized across the community of transplant centers. And I think it's because we still need a better molecular understanding of what's going on. But most of the center will be using as like a base treatment of plasmapheresis associated with IVIG and corticosteroids. And different center will include other treatment or adjunct adjunctive therapy like anti-CD20 antibodies, IgG degrading enzymes. Some centers will include, as ours, proteasome inhibitors to treat antibody-mediated rejection. And I wanted also to touch base on the new emerging treatment target that we are using in the setting of AMR, specifically chronic active AMR, using the CD38 agent to deplete natural killers, anti-CD38, and that deplete NK cells and also target activated B cells. We started a pilot study at MGB, and we are enrolling patients with chronic active AMR to receive treatment with anti-CD38 antibodies. And just because we talked about the chronic active AMR, I wanted as well to show you this specific criteria that are the definition of chronic active AMR, which is defined by the presence of a double contour and a hypercellularity on the glomerular level, and absence of immune deposition most of the time. And this diagnosis is poorly associated with a poor prognosis, with a hazard ratio of losing the allograft within the year of 3.7. This is electronic microscopy showing the peritubular basement membrane multilayering and change in the lamina densa associated with the diagnosis of chronic active AMR. So another question where we can also talk about other cause of late loss of the allograft, a 26-year-old female, history of transplant with a creatinine in the range of 1.1 on tacrolimus and mycophenolate, and her creatinine was found to be up to 1.8, concern for late allograft dysfunction after a few years post-transplant. You proceed with kidney allograft, which shows chronic AMR. What do you think is the leading cause of de novo DSA in this patient and the poor prognosis? And the options are HLA mismatch, medication non-adherence, and previous T-cell mediation rejection or T-cell mediated rejection. And the answer is the medication non-adherence. So this figure from a paper published in 2018 in the AGT, they looked at the attributed cause of antibody-mediated rejection, and they found that almost half of them were related to non-adherence to treatment. They looked at some specific risk factor in the population, and they found that patients coming from low social economic background, those transitioning from pediatric to young adult age, represent high risk for social economic instability and also risk for non-adherence to the treatment, leading to more and more diagnosis of chronic antibody-mediated rejection. So another case study that will allow us to discuss further items and etiologies for late allograft loss. A 50-year-old woman originally from Jamaica, in-stage renal disease in the setting of collapsing GN, immune complex. She received a deceased donor kidney transplant in 2016, which was complicated by a low graft function, delayed graft function, and creatinine was still up to 2.7 after 1 month. She was on tacrolimus, mycophenolate, and prednisone. Biopsy was done, and these are the main criteria, characteristics of the donor: 52, cardiac arrest, CPR, history of sarcoidosis, and KDPI of 45%. And here is the biopsy of this patient. As you can see in the silver stain, you can already start picking the fibrosis, and you can notice a striped pattern of the interstitial fibrosis. And you can also see that the vessels don't really look healthy in this patient. And here we can have the final report where it's calling it no sign of active rejection, but presence of moderately advanced chronic changes of the parenchyma, most likely representing donor-related disease. Remember the donor age and the history of some vascular risk factors, with presence of pretty extensive focal tubular atrophy and interstitial fibrosis. 40 to 50% of the cortex is involved with IFTA, and with severe arterial and arteriolar sclerosis. So this patient actually showed two pattern of injury to her kidney. First, all the changes related to the risk factor associated with the donor, but also sign of CNI toxicity. This is one of the main immunotherapeutical choice for the majority of our patient, and it's unfortunately associated also to high risk for nephrotoxicity. And you can see that there are very specific features that are associated to the tacrolimus nephrotoxicity that includes tubular atrophy and this kind of striped pattern of fibrosis, and also involving the vessels, like they will be showing some swelling, shrinking, sometimes some pseudothrombi, and nodular hyalinosis in the arteriolar walls. And we also can see at the early acute setting changes in the tubules with isometric vacuolization of the proximal tubules, as you can see in this figure. So to carry on with the case of this lady who had a biopsy that showed these changes related to the donor risk factors, but also some CNI toxicity. So this patient was switched off tacrolimus to receive the CTLA-4 immunoglobulin belatacept, and then had a slow taper of tacrolimus. And the idea was, because she has these severe signs of CNI-associated nephrotoxicity, is to spare her being on tacrolimus. And by September 2016, 5 months post-transplant, we saw an improvement in her creatinine that went down to 1.6. However, 1 month later, she developed mild discomfort in the area of her transplanted kidney, with a creatinine again up to 3.3. And we did another biopsy, and this is what the biopsy showed. It showed acute vascular allograft rejection with a BAMF type 2AB, with interstitial nephritis and also infiltration of the wall of the vessels, and some acute antibody-mediated rejection features with diffusely positive C4D stain in the peritubular capillaritis, as you can see here, and mild chronic changes of the parenchyma as well. So this patient has also on her biopsy some signs of T-cell mediated rejection, and this is also a feature that we can see later on, although it's less usual to see T-cell mediated rejection years after transplant. It's mainly seen during the early phases, early years after the transplant, and this is the definition of T-cell mediated rejection, where we will have signs of tubulitis with the membrane of the tubules infiltrated by inflammatory cell, interstitial inflammation, and also in the severe cases, intimal arteritis. So just to go back to the case, so this patient, remember, we switched her off tacrolimus to belatacept to try to spare nephrotoxicity related to the tacrolimus, and she was started on the belatacept, which has been a game changer, and thanks to the benefit study published in 2016 that showed in patient with high risk for nephrotoxicity related to CNI and improved in EGFR, but was still associated with lower incidence, lower to mild incidence of de novo DSA, and also a risk for rejection. So although switching to belatacept will improve the EGFR and the creatinine level, but it's still associated with risk of rejection. And an important black box associated with the use of belatacept is it's contraindicated completely in recipient who has no immunity for EBV before transplant because of the increased risk of PTLD, post-transplant lymphoma disorder in patients who are EBV recipients. So let's go back to the case and look at the other features of the biopsy in this same recipient. So it showed also on her pre-transplant biopsy and as cause of a kidney disease, a collapsing glomerulopathy. And here we can move to other causes for loss of allograft, late loss of allograft. One of the major causes is recurrent membranoproliferative GN or recurrent GN in general, and the most worst prognosis and the earliest recurrence happens with the MPGN, the membranoproliferative GN, that happens in younger recipient with a lack of clear consensus as regard of the role of immunosuppression to prevent recurrence. MPGN is a pattern, not an injury, but C3GN is the one that has been reported to recur at a higher rate, at about 66.7% and pretty early, with a median time of 28 months post-transplant, with risk of allograft loss up to 50% in patient with C3GN, and a median time of 77 month post-transplant, as showed in this study. Another cause of loss of allograft because of recurrent GN is patient with high-risk APOL1 allele genes, and especially if the donor is a relative, family-related donor. So we try, obviously, to avoid these kind of donation within the same family members. It's associated with a hazard ratio of recurrence of 2.3 and a high risk of allograft loss. BK nephropathy is also another cause for late allograft loss. This is also can be a board question. The BK nephropathy can occur early within the first year post-transplant, while patients are still on high dose of immunosuppression, and it's usually associated, unfortunately, with a poor prognosis, especially that there is no standardized treatment or obvious treatment for the BK nephropathy, and we usually tend to reduce the immunosuppression as an approach to control the viral load and the inflammation related to the viral load. So to conclude, the take-home messages is that antibody-mediated rejection represents the leading cause of late allograft failure.